Hello guys, welcome back to Clinically Clear. So today let's cover everything about sclera. Starting with the what is sclera? Sclera is basically the outermost covering of the eye. It is a fibrous tunic. Posterior 5/6 is sclera. Basically this much is sclera. Anterior 1/6 is cornea, which is transparent. Sclera is opaque. So sclera is the thickest at the posterior pole, that is around the optic nerve. It is very thick. Sclera is the thinnest just posterior to the insertion of recti. Very important. Posterior to the insertion of recti, sclera is the thinnest. It is thickest at the posterior pole around the optic nerve. Then coming to the layers of sclera. Basically, you have the outermost episclera, which is just beneath the Tenon's capsule. Then you have the sclera proper, and then innermost layer is the lamina fusca. Basically, the sclera, episclera, it is the vascular layer of sclera. You have a superficial vascular plexus and a deep vascular plexus. The sclera proper is avascular. Sclera proper is avascular. It just has dense, irregular arrangement of collagen fibers. That is why sclera is opaque. Then lamina fusca, it is the innermost layer. And episclera joins with the Tenon's capsule at the limbus. Episclera, Tenon's capsule, conjunctiva. They all three join at the limbus and then they continue as cornea. So that is important. So outermost episclera, sclera proper, lamina fusca. Episclera is vascular, sclera proper is avascular. First, let's look at episcleritis. Episcleritis is the benign recurrent inflammation of episclera due to superficial vascular plexus. Now, inflammation has to have some vascular component. There is vasodilation, increased vascular permeability. So basically, because of the superficial vascular plexus inflammation, you get episcleritis. In the episclera, I told you, you have a superficial vascular plexus, deep vascular plexus. It can spread to the Tenon's capsule, but it does not spread to the sclera proper because it is superficial. Episcleritis is most commonly idiopathic, but it can also be associated with autoimmune diseases like rheumatoid arthritis, systemic lupus erythematosus, SLE, rheumatoid arthritis. It can be a hypersensitivity reaction to tubercular antigens. So infections like tuberculosis, herpes zoster virus. So these are the risk factors. It is commonly seen in young adults. Then symptoms: acute onset of redness. See here, one thing you have to remember is in episcleritis, it is bright redness. There is no bluish, there is no violet, nothing. It is just bright redness, acute onset, with or without ocular discomfort. You can also have like sort of asymptomatic. Apart from the redness, you can also have no other symptoms, or you can have ocular discomfort like mild pain, foreign body sensation, burning sensation that can be present. Pathology, what is it? Basically, it is inflammation. So you'll have inflammatory infiltrate, edema in the episclera. Simple. Coming to the signs. See, you can have two types of episcleritis: diffuse episcleritis and nodular episcleritis. Diffuse episcleritis, it is diffuse inflammation of the episclera. There is no patchiness. It is just diffuse, irregular inflammation of the episclera. So you will see wherever the diffuse inflammation is there, you will see bright red areas. As you can see here, bright red vascularity, inflammation. Then nodular episcleritis, you will have red flat nodules. You will have red flat nodules of inflammation. Yeah. Bright red, again, bright red, very important. Red flat nodules which are mobile, which can be freely moved. It is in the episclera, right? Episclera is above the sclera proper, so you can easily move it. So this is nodular episcleritis. Most common is diffuse episcleritis. Diffuse episcleritis is more common than nodular episcleritis. Differential diagnosis, it might just be conjunctivitis, red eye. Scleritis versus episcleritis. This is very important. See, episcleritis is seen in young adults. Scleritis is seen in elderly females. Pain, episcleritis, I told you, either it can be absent or it can be very mild pain, discomfort. Scleritis, you'll have severe pain or a moderate amount of pain. Episcleritis is self-limiting. Scleritis, no, it can progress, it can have complications. And I told you the color in episcleritis, it is bright red, the superficial vascular plexus. It is very superficial, bright red. Whereas in scleritis, you have a violaceous hue, violet color. I'll come to that when I teach the scleritis. But just remember that violaceous hue in scleritis, bright red in episcleritis. Then no necrotizing episcleritis, no necrosis, nothing. Whereas in episcleritis, it may be present. There is a type known as necrotizing scleritis, where you can have necrosis, but otherwise episcleritis, there is no necrosis. Scleritis, it may or may not be present. Then blanching test or vasoconstrictor test, where we add 2.5% phenylephrine eye drops. 2.5% phenylephrine, it is a vasoconstrictor. So what happens in episcleritis? The inflammation is very superficial, right? Superficial vascular plexus. So the eye drops reaches the vascular plexus, causes vasoconstriction, redness disappears. So blanching is present. Whereas in scleritis, it is the deeper involvement, deeper inflammation. So the eye drops will not cause vasoconstriction. So blanching will not happen. This is how they differentiate in the OPD between scleritis and episcleritis. They'll add 2.5% phenylephrine in eye drops. If it disappears, episcleritis. So anyways, it is self-limiting. So simple treatment. Whereas if it does not disappear, it could be something more serious like scleritis. So how will you differentiate? Age, color, pain, the areas of necrosis, vasoconstrictor test, and the clinical course. Then coming to treatment. I told you episcleritis is completely self-limiting. It is not a very serious condition. So you will give symptomatic treatment. You will give topical low-dose steroids like fluoromethalone to reduce the irritation. You will give topical NSAIDs or systemic NSAIDs if it is very, very severe. NSAIDs, systemic NSAIDs if it is very, very severe. You'll give cold compressions, you'll give artificial tears like carboxymethyl All this is to basically reduce the irritation, reduce the foreign body sensation, reduce the inflammation, symptomatic treatment, but nothing too serious. Next, coming to scleritis. Now, scleritis, it is less common but is way more severe. It is the acute inflammation of the sclera proper. But the sclera proper is avascular. So, how is it getting inflamed? Because of the infiltration spreading from the deep vascular plexus of the episclera. So, the deep vascular plexus of the episclera is very, very close to the sclera proper. So, from there, there is acute inflammation of the sclera proper, resulting in scleritis. And as I told, it is most commonly in elderly females, scleritis. Why elderly females? Because the most common causes, scleritis is associated with autoimmune connective tissue disorders. Very, very important. Rheumatoid arthritis, especially rheumatoid arthritis, also SLE or polyarteritis nodosa. All these are the most common causes of scleritis, especially in elderly females. You can also see it in granulomatous conditions like leprosy, TB. This can also be idiopathic. You can see it in metabolic conditions like gout, thyrotoxicosis. You can have surgically induced scleritis where within 6 months of post-operation, patient gets scleritis. So, patient would have undergone an ocular surgery and 3-4 months later scleritis. So, that is surgically induced scleritis. So, you can have metabolic, thyrotoxicosis, gout, granulomatous TB, leprosy, most common elderly females, rheumatoid arthritis, SLE, polyarteritis nodosa, that is autoimmune connective tissue disorder, idiopathic, and surgically induced scleritis. Here I told you there is much more pain compared to episcleritis. There is much more pain, there is much more foreign body sensation, irritation, burning, lacrimation, photophobia. And here it is violaceous hue. Violaceous hue is very, very important because here the vessels are deep. Whenever vessels are deeper, because of the tissues above, you don't see the redness. You see the bluishness. So it is violaceous hue in scleritis. Very, very important symptoms. Patient presents with bluishness, violet purple color. Then coming to the types. Types of scleritis. You have broadly infectious and non-infectious or immune-mediated. Immune-mediated is more common, non-infectious. Now, infectious is when you have scleritis. Along with that, if you see stuff like purulent exudate, pus, fistula formation, ulcer, all that is indicative of infectious. Especially purulent exudate, it is indicative of infectious scleritis. Whereas non-infectious or immune-mediated scleritis, it can be anterior or it can be posterior. Posterior scleritis is very, very rare. Anterior scleritis can be further classified into non-necrotizing and necrotizing. Okay, non-necrotizing is more common. Non-necrotizing can be further classified into diffuse and nodular. Just like episcleritis, here you have diffuse non-necrotizing anterior scleritis and nodular non-necrotizing anterior scleritis. Okay, now diffuse is the most common type of scleritis. Diffuse non-necrotizing scleritis, it is the most common type. Again, you'll have diffuse inflammation, so you'll have diffuse violaceous hue everywhere. So that is diffuse. Nodular, just like how you had red flat nodules in episcleritis, here you'll have purple or violet flat nodules which are immobile. It is in the sclera proper. In episcleritis, you could move that nodule around. Here you cannot move it around because it is in the sclera proper. So nodular non-necrotizing scleritis. Then coming to necrotizing. Now, necrotizing can be with inflammation or without inflammation. With inflammation is where you have acute severe inflammation in the sclera proper. There's a lot of pain. It leads to areas of necrosis. Wherever this necrosis is there, sclera gets thinned out. And when the sclera is thin, the underneath uvea is easily seen. Uvea shines through. Uvea is nothing but vascular layer of the eye. So vascular tunic. So that vascularity is seen as this bluish violaceous hue. So there is scleral thinning, very, very important. Necrotizing scleritis is always associated with scleral thinning because there is necrosis of the sclera proper. Without inflammation, necrotizing scleritis without inflammation, also known as scleromalacia perforans, very, very important. Scleromalacia perforans, it is especially seen in rheumatoid arthritis, very, very important. Rheumatoid arthritis, scleromalacia perforans, necrotizing scleritis without inflammation. There is no redness, no pain, so there is no inflammation. But then there is autoimmune destruction, so there is atrophy of the sclera. So when the sclera atrophies, it gets thinned out. Again, the uvea shines through. So it is sort of necrosis only, atrophy only. So it gets thinned out. Uvea shines through. That is why you have the deep blue violaceous hue. Again, in scleromalacia perforans also, you will have full bluish hue in the sclera. Complications, I told you, scleral thinning can lead to staphyloma. Staphyloma, I'm going to teach next. Uvea can lead to uveitis. Glaucoma, ulcerative keratitis in the cornea. Posterior scleritis can lead exudative retinal detachment, can lead to exudative retinal detachment. Now, this you just have to remember. Most important is staphyloma. Staphyloma and scleritis, very common because scleral thinning is there. Investigations, see, you want to rule out the causes. You want to check for the causes. The causes was what? Autoimmune connective tissue disorder. So you'll check for rheumatoid factor, ESR, CRP, anti-nuclear antibodies for SLE. So all this you'll check as serological test. Then to rule out metabolic causes like gout, you will check for serum uric acid. To rule out thyrotoxicosis, T3, T4, TSH. To rule out granulomatous conditions like TB, you can do chest X-ray, Monto test. To rule out granulomatous conditions like syphilis, you can do VDRL. So you'll do the tests for the etiological causes. So that is investigation. Last, coming to treatment, infective scleritis, do not give steroids, do not give immunosuppressants. It will only worsen the infection, only give antimicrobials, very, very important. Whereas non-infective immune mediated, which is basically autoimmunity, non-necrotizing is not that, it's not a problem. Example, diffuse, nodular, not a big problem. You just have to give topical steroids, it will reduce the inflammation, and for the pain you will give NSAIDs. Whereas necrotizing, this is a problem because you'll have scleral thinning, you'll have necrosis, lot of pain. So lot of pain depends if it is without inflammation or with inflammation. So what will you give? You'll give both topical and systemic steroids. You'll give both topical and systemic NSAIDs. You'll give immunosuppressants to suppress the autoimmunity. It is immune mediated, right? Non-infective is immune mediated. So you'll give methotrexate, cyclophosphamide, immunosuppressants. And because if there is scleral thinning, for necrotizing, because there is scleral thinning, if it is very, very severe, you will give surgical patches. You will do surgery where you will put scleral patches. So that is very important. So infective, give only antimicrobials. Non-infective, non-necrotizing, just topical steroids and NSAIDs. Necrotizing, systemic steroids, topical steroids, NSAIDs, immunosuppressants, and surgical patch of sclera if there is scleral thinning. What does scleral thinning lead to? Why do we do the surgical patch? To prevent the staphyloma. So staphyloma is a localized bulging of the outermost tunic of the eye, either the cornea or the sclera. And it is lined by the uvea which shines through. I told you, when there is scleral thinning is there, uvea shines through. If this thinned out sclera, scleral, corneal, thinning, weakening, all this, because of the thinning, it will start bulging. Because from inside pressure is there, no, it is bulge. This localized bulging lined by the uvea, that is known as staphyloma. Anatomically, you can have various sites. Anterior staphyloma, anterior bulging, that is pseudocorneal ectasia. Basically, what happens when there is a perforating corneal injury, when there is a corneal ulcer, we know that cornea, it heals by scarring, fibrosis. The scar tissue is very, very weak. It is known as pseudocornea because it is not actual cornea. The hole is just filled with pseudocornea. So the pseudocornea will bulge out. It is lined by the iris. See, here you have the iris. The iris will line this anterior staphyloma. Next, coming to intercalary staphyloma, which is at the limbus, as you can see, cornea and then sclera. Intercalary staphyloma, it is at the limbus. Again, it is because of the weak corneal scar tissue. And here it is lined by the root of the iris, not the iris. See, this is the root of the iris. So at the limbus, it will be lined by the root of the iris. Again, due to perforating corneal injuries and peripheral corneal ulcer, because limbus, right? So peripheral corneal ulcer. And again, see, both of these are corneal, pseudocorneal scar tissue ectasia, very close to the cornea. So corneal curvature will get affected. So they can lead to corneal astigmatism as well. Next, coming to ciliary staphyloma. Ciliary staphyloma is 2 to 3 mm away from the limbus. So go 2 to 3 mm away from the limbus, you will see ciliary staphyloma. Ciliary staphyloma is lined by the ciliary body. So here you have the ciliary body that will line the ciliary staphyloma. And here this is due to necrotizing scleritis. I told you necrotizing scleritis, main complication is staphyloma. Also end stage glaucoma where the intraocular pressure is so high that it will push the sclera out. It will cause the weakening, thinning of the sclera and it will push it out. So ciliary staphyloma 2 to 3 mm away from the limbus. Equatorial staphyloma along the equatorial line. So along the equatorial line, you'll have equatorial staphyloma. Here again, due to scleritis or pathological myopia where there is excessive stretching of the eye. And here it is lined by choroid. What is the uveal tissue here? It is all choroid, choroid, choroid. So choroid will line the equatorial staphyloma. Last, coming to posterior staphyloma. Posterior staphyloma, most common causes pathological myopia. Very, very important. Pathological myopia leads to mostly posterior staphyloma. Also, posterior scleritis. Posterior scleritis, if it is necrotizing type, again it can lead to posterior staphyloma. Here again, of course, it is lined by the choroid. Behind the equatorial line, it is at the posterior part. Behind, this is the equatorial line. Behind the equatorial line, you have the posterior staphyloma. So what is staphyloma? Localized bulging or outpouching of the outermost tunic, either sclera or cornea, lined by the uvea, where the uvea shines because of thinning, weakening. You can have anterior staphyloma and intercalary staphyloma. Anterior staphyloma in the cornea, intercalary staphyloma at the limbus, where the corneal scar tissue, pseudocorneal scar tissue that bulges out. Then you can have ciliary staphyloma 2 to 3 mm away from the limbus. You can have equatorial staphyloma along the equatorial line. You can have posterior staphyloma behind the equatorial line. That is it for sclera. A bit of a long video, but I've covered the whole chapter. Thank you for watching.